Anjalee Khemlani. Welcome to Yahoo Finance Presents. In this episode, we will be speaking with one of the world's top infectious disease experts and the face of the coronavirus outbreak in the U.S., Dr. Anthony Fauci. We discussed the current status of the outbreak in the country as states continue to reopen despite some problem areas, as well as the U.S. relationship with the World Health Organization and his thoughts on the global vaccine race. Dr. Fauci, thank you again for joining me. And I want to start with one of the most hotly debated topics right now, which is asymptomatic transmission. I'm sure you've heard the World Health Organization yesterday gave out some information from member states' data that suggested that possibly asymptomatic people are less likely to transmit the disease, and they were differentiating between asymptomatic and pre-symptomatic. So I'd like your thoughts on that.
Yeah, I think a lot of confusion has emanated from this issue of an asymptomatic person and asymptomatic transmission. When you look at the number of people, if you look at all the cases of coronavirus infection, about 25 to even up to 45% of the people are asymptomatic. The real question is, what is the percentage of infections that go from an asymptomatic person to an uninfected person? And that's something that we know it occurs, but we're really not sure exactly what the extent of it is, because it's very difficult to measure that. You can determine how many asymptomatic people are merely by doing screenings and finding out. But when you're doing epidemiology, so what the WHO said yesterday, that although there are asymptomatic infections and although asymptomatic people can transmit, they are not the drivers of the outbreak. The drivers of the outbreak are people who are symptomatic and transmit to others. That doesn't mean that asymptomatic transmission doesn't play a role, but it isn't the major driver of the outbreak. And yet there's this confusion when people talk about who's asymptomatic infection and who's driving it. But that's really what the WHO meant.
Okay. And talking about confusion, one of the things that I'm sorry I have to ask you about is hydroxychloroquine. The retraction of that study in The Lancet last week, which caused the World Health Organization to pause their trials, was based on questionable information. So I'm curious, has that changed your opinion of it at all? I know you've called for more trials. And is there a difference between, the treatment version, treatment option, or the way the president is using it as a prophylactic?
Right. The answer will come with the clinical trials. I think there's a lot of back and forth about what is a good trial, like the one that was retracted or not. I think the important thing for us all to do is that I've said for so long and so many times is that the definitive proof whether something is safe and effective, whether it works or not, is a randomized controlled trial. Those trials are being conducted, and we will know the answer, and we will go with the science rather than going back and forth in things that are sort of suggestive but not necessarily definitive. As scientists, we want to go with the definitive trial.
Fair enough. Speaking of the World Health Organization, the president did announce that we are ending our relationship, the U.S., with it. Is it your sense that this is affecting the scientific community? We've obviously had collaborations globally for such a long time, either through the organization or outside. How is this disrupting that?
Right. The WHO is an imperfect organization, but it's an important organization. I've dealt with them over many outbreaks, over many years. We still interact with them. We have a weekly conference call where they bring together all of the different countries who talk and update us about exactly what's going on in their individual country. And that's important for us. That's not to say that they haven't made mistakes and missteps in the past, but in general, it's an important organization.
One of those missteps based on the U.S. Interpretation is the way that they handled the outbreak in China and holding them accountable. That is the reason behind President Trump calling for an ending that relationship. But their vaccine candidate is pretty far ahead, even though we have Moderna as a front runner. So if they do make it to production and successfully get that out there, is it possible we'll see their vaccine used in the U.S.?
Well, the answer is that there are a number of candidates that look really quite favorable, that are in various stages of clinical trial. My prediction would be that we would have more than one candidate that ultimately gets to the point of proven to be safe and effective. So I don't think we're going to have a situation where one country or one organization has a vaccine that they are or are not going to share with others. I believe that there will be enough favorable responses to the large clinical trials, and that the plans now to make hundreds of millions, if not billions of doses will actually come true. When that happens, it's very difficult to predict. We're on a course right now where we believe, at least in a couple of the candidates, that when we start the phase 3 trial, let's say in the first week or so of July of this year, that by the time we get to the early to mid fall, there will be enough people accumulated in the trial and enough infections that we might have an answer by the end of this calendar year. That's for one of the candidates. There are other candidates that are ahead of that, behind that. We'll just have to wait to see what happens. But I'm cautiously optimistic. And I know that's a reasonable question that you ask. Is this one going to beat that one, or the other one going to beat? But that's not what it is. It's a group of candidates, most of which actually have pretty good preclinical data. So we're counting on having success with more than one, we hope.
Dr. Fauci, your favorite phrase, cautiously optimistic, and you just used it, is something you're very, very keen on using, and I understand why. But another thing you also say is that, like you just said, you're looking for that indication of being proven as a vaccine, and I think that sometimes gets condensed to there's going to be a vaccine this year. And while that is technically true, I think we should differentiate, and I'd like your thoughts on the differentiation on what that means for the general public, even if it is at risk, even if you produce that risk and you do get that indication. What does that mean for the general public versus, say, health frontline workers and essential workers?
Okay, so thank you for giving me the opportunity to answer that. It's a complicated question, but it's an important question. So first of all, everyone should understand when either I or other people talk about projections of vaccines, when you may or may not get it, you've got to realize there is no guarantee at all that we are going to have a safe and effective vaccine. We feel, and I'll use my terminology, cautiously optimistic that we will actually be successful. So we're counting on being successful. The rate at which we do it is something important. We say we're doing it very quickly and at risk. It isn't risk of safety. We're not compromising safety. We're not compromising scientific integrity. What we're doing is that we're going along at a pace where, under the normal development of a vaccine, you would go to one step, wait to see if you're successful, then make an investment in the next step. Then when you're successful, make an investment in the next step. The reason for that is caution, because if you get stopped at this step, you don't want to have to waste all the money of the investment. Companies do that because they can't risk resources. Given the urgency of this situation, we've made a decision with the support of the federal government that we will proceed at risk. We will start making doses of the vaccine before we even prove it was effective. If it isn't effective and isn't safe, then the only thing that would have been lost is money. But we feel it's worth it to gain those extra months. And that's the reason why we're moving more quickly than usual, because when people hear quickly, they say, oh my goodness, are we compromising safety? Are we compromising scientific integrity? The answer is we're not. Given that, we project that we will be able, if we're successful, Anjalee, and that's a big underlining, if we're successful, it is likely that we will have doses to be distributed to people by the end of this calendar year or the beginning of 2021. And then you ask, well, who's going to get it? Obviously, ultimately, you want everyone who needs it to get it. But the prioritization has always been, you give it to the healthcare workers who are going to be deliberately putting themselves in harm's way to help people. They need to be protected. Then you have a number of vulnerable people, the people who have a greater chance of getting the complications of infection, the elderly, individuals who have underlying disease. And then you go down the line until ultimately you get everyone. That's what it is. And it's something that, again, we're aspiring for that. But when you're dealing with the development of vaccine, there's never a guarantee that you're going to get it.
Really quickly on that compressed timeline, do you see that being a change that might be adopted, after we get out of this as something that changes in R&D?
Well, it depends on the urgency and the need for a particular product. If you have 3 or 4 interventions, be they drugs or vaccines, and people are being well treated with it, and you want to add an additional one, it's very likely that that would not be on an accelerated speed because it isn't necessary. When you have nothing like we have now, we need a vaccine, we need therapeutics. Then you do the balance of proceeding quickly, but always safely with attention to the scientific integrity of the study.
Fair enough. I know that your work with the White House task force is ongoing. You've said that, even though we're not getting those daily briefings. So are you still regularly in touch with the president? Is it just the vice president showing up? And what is the main concern right now? What's the focus?
Well, it's both. I mean, obviously, I was with the president last week. I'm going down today, literally in a couple of hours, to meet with the vice president and the coronavirus task force, as well as meeting with the subgroup of doctors who are a component, but not the entire task force. So we still do it. I mean, the number of, when things were at their most intense during the major issue that we had with New York metropolitan area was dominating with infections. We were at the White House coronavirus task force like every day, including Saturday and Sunday. That's not what we're doing now. We certainly still have a very strong presence in the task force, but it isn't as visible. You don't see it as much because things that are concentrating on right now are how do we safely reopen the government? How do we get these cities, these towns, these counties to try to get some sort of normality, to get the economy back? That's most of what's being discussed. But the behind the scenes activity, concentrating on the health and other issues, that is as good as it's been.
Okay. What about testing? I know that's one of the issues. We've seen, the ramp up of production of swabs. Labs are increasing their capacity. All of the numbers are increasing, but we still hear anecdotally about sort of conservative use of these PCR tests specifically. So I'm curious on your thoughts on what the biggest hurdle remains to access to testing, as well as the at-home component, which some people are saying could address those health inequities that we're so focused on.
Well, I think the testing situation, first of all, is orders of magnitude better now than it was if we were having this discussion a couple of months ago or even last month. It gets better and better. We have more tests available. We have the associated material necessary for the test more available than they were. I screen a lot. I mean, in addition to the visible things you see me, usually late at night, I'm calling up people in different cities and different counties and trying to find out how things are going. And in the beginning, there was a concern that they didn't have this or they didn't have that. But now more and more, we're seeing that the kinds of things that were problems before are being solved. They're not all solved. They're never all solved. But it's significantly better than it was. In fact, I have a call tonight with constituents from a number of cities throughout the country who are in the trenches doing the things that we're talking about to try and get a feel for how it's been compared to a week or two ago.
Okay. And mass gatherings is obviously something that you're focused on in this reopening concerns. Are you concerned about the protest becoming super spreader events, as the CDC director suggested last week? And does allowing them, is it harder to reinforce sort of those social distancing measures as a result? Is that a concern?
Well, obviously, it's a public health concern. I mean, we all recognize the constitutional right and even the compelling reason, given the situations now of people expressing their thoughts in a demonstration. So it's not anti-demonstration at all. But you have to balance that with the public health imperative that we have to not spread infections. So you could tell people that it is going to be risky to demonstrate, but people will demonstrate anyway. You've got to be realistic. You can't live in your little cocoon and say, well, you shouldn't demonstrate, and yet they do. So as public health officials, what we say, if you are going to demonstrate in a non-violent way, a peaceful demonstration, please be sure to wear a mask all the time. To say keep physical distance is a non-starter because the very nature of a demonstration, you see people in crowds. But wear a mask, and I know when things get animated, people start to chant and shout. Please resist the temptation of pulling your mask off. Leave your mask on if you do that.
Fair enough. And looking at, this is a little bit of a pivot, but looking at your experience with HIV, I know that's something that has been easy for you to follow that playbook when it comes to knowing what to do about contact tracing, with the HIV treatment cocktails, the idea of using Gilead's remdesivir in coordination with others. What are some of the other sort of experiences that you're applying from your time then?
Well, I mean, there are so many aspects of these outbreaks that are similar and so many that are very different. Let's take the scientific side. When we first saw the result of remdesivir, which was a significant effect, but modest in effect. So it was statistically significant, but it was a 31% diminution in the time it took to get back to recovery, in the sense of leaving the hospital, because this was a study that we did in hospitalized patients with lung disease. It reminds me way back in the 80s, when I was doing the same thing with HIV, and we had a single drug that looked like it was giving a good effect, and it did, but it was a single drug, and we needed to do better. And subsequently, over the period of time, we had a second drug, then a third drug. We did it in combination with two, and then finally, we landed on the triple combination that completely transformed the lives of HIV-infected individuals. And then from that, we developed a prophylactic, or a drug that if you give a single pill a day, it is highly successful in preventing the acquisition of HIV. So if you look at the analogies, that what we see now is a step-by-step improvement in the treatment, potential prevention, and then ultimately a vaccine. So there are analogies. One is a chronic infection that lasts over years. One is an explosive, highly transmissible. So they're very, very different. But the development of interventions really do have somewhat of an analogous pattern.
What about right now, where we are? You've been watching, you've been updating us on every single, issue or update that we've needed. But are there things that maybe didn't pan out the way you expected, or things that you're still waiting to pan out?
Well, I mean, that's a very broad question. It's very, very difficult to apply it. I'm not really sure exactly what you mean when you say pan out. I mean, we're in a very difficult situation that we're dealing with literally a highly, highly transmissible virus, that it is so different from other viruses. When it was doing public health interventions, was modestly or relatively easy to contain. We know now that, and this came out yesterday in the news, that the shutting down of a nation, the way we did here in the United States and way virtually every other country, with few exceptions, did, was to lock down, was responsible for preventing tens and tens and tens of millions of infections. We've never been in a situation like that ever in history, where we had to essentially shut down the planet, is what actually happened. I mean, if you look at the globe and the more than 200 plus countries that have been afflicted, almost all of them had that shutdown. That is unprecedented. Right now, we're faced with a real challenge. You can't stay shut down forever. So it's going to have to be a balance between containing the potential resurgence, which we will hopefully have the capability of doing, at the same time as we march forward to some sort of normalization and reopening not only our country, but the rest of the world. Because if you look at what's going on, so many other countries are trying to do the same thing we're trying to do. The question is, we needed to do it prudently and safely in the context of our ability to respond when you do see these bit of resurgences.
And a final question, are you breathing a sigh of relief yet?
A sigh of relief? No. I never get ahead of myself. I'll breathe every sigh. As Yogi Berra used to say, it ain't over till it's over. And that's when I'll breathe a sigh of relief, when we're really completely out of this, right?
Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases, thank you so much for joining me today. It was a pleasure.
Good to be with you. Thank you for having me.
Joining me now is Dr. Robert Redfield, Director of the Centers for Disease Control and Prevention. Dr. Redfield, good morning. Thank you so much for joining me today.
Thanks for having me.
Obviously, we have to touch on the news of the day, which is the CDC taking action on evictions and the moratorium on them. As we're seeing this pandemic continue to affect Americans, explain the thought process on why the CDC was able to take action while we're waiting for Congress to sort of make more progress on something like this.
Well, I think the importance to recognize that homelessness is an important risk for COVID transmission. And the opportunity to try to prevent individuals from losing their stable housing, where they would either go into concongruent housing with other individuals and therefore put at risk potential for further COVID spread, or tragically could actually become homeless. And so using our public health authority, seeing this as a public health risk, we're part of the president's executive order that wanted to try to interrupt evictions at this period of time. So for the next 4 months, there's an interruption of evictions for individuals that make less than $99,000 annually, or a couple greater than, I think, $198,000.
Could the CDC extend this if nothing happens in Congress in December, by December?
It's conceptual. It could be extended. Obviously, we're doing this in partnership under our public health authority with HUD to make sure that we try to minimize the disruption that may be caused by an increase in homelessness or evictions.
And clearly having people, cramped together in spaces is something that is continuously a struggle for the country, and something that I'm sure you're focusing on. And, after Memorial Day, you mentioned that we saw a spike in cases within that 2-week period. Labor Day is coming up. What are the concerns there?
I think it's really important because we did, in fact, see the Memorial Week surge, and then we saw a surge after 4th of July. We're actually doing very well now. We're improving. The cases are coming down substantially. We've had probably close to a 40% decline in cases from the time we were peaked in late July, and deaths are coming down. We want to keep that trend. Clearly now with Memorial Day, we don't want it to become a spreading event. So we're really appealing to everyone to be vigilant about wearing a mask, to be vigilant about social distancing, to be vigilant about hand washing, to be smart about crowds and really limiting any crowding that they would do. Stay away, obviously, from crowded bars for any crowded spreading event. And the other thing I'm advocating people do or really reflect on this Memorial Day weekend is to talk in their families about the importance of getting the flu vaccine. The flu vaccine is now available. Flu season's about to start. So it is really important. I don't think you can stress enough on your news outlet how important it is to take serious Labor Day and to be really vigilant about the mitigation recommendations that we have. And let's make sure that Labor Day is not a spreading event. If it keeps with the downward trend, we'll be in a strong position as we enter October when the flu season really gets started. But if we have a spreading event right now, with Labor Day, then 3-4 weeks later, we're going to have that surge of new cases, and it will be much more complicated. So really appealing to the American public to let's be extremely serious this Labor Day about embracing the mask, the hand washing, the social distancing, avoiding crowds. And I would argue, make a family commitment to get the flu vaccine.
worst case scenario, if we do in fact end up with another surge prior to the flu season starting, what are the sort of strategies that you've had in place or that are being developed to help so that we don't have a repeat of what happened earlier this year?
Well, I think that's the real challenge. I mean, that's the real challenge, Anjalee. I mean, I think that I've said in the past that this could be one of the most difficult public health winters we've ever had, with the convergence of flu and COVID. However, if we're really vigilant about these mitigation steps, we're seeing the summer transmission of flu right now, because we do get flu all year round, but flu over the summer, late spring and summer, is the lowest level we've ever seen. So it means that these mitigation steps that we're using for COVID are also impacting flu. But if we do have a lack of mitigation and we do have a surge of COVID, you can see that if we have that surge now, it will end up peaking 4 to 6 weeks from now. That's the same time we're going to start to see flu. So again, I think all I can do is really appeal to the important power that each of the people in our nation have to become part of the solution by embracing these important mitigation steps.
One of the other things, obviously, that's a conflating issue is school reopenings. And we've seen already college campuses having to reverse reopenings and move to distance learning, as well as other schools. Your thoughts on that and what we can do right now, and how the schools can, in fact, tackle this? I know there are some areas where school is in progress, especially for younger kids.
Yeah, first I want to say reopening schools K through 12. I've said it before, I'll say it again. I think it is a critical public health decision that the public health of the K through 12s are best served by getting back to face-to-face learning. So we really do need to make a commitment to figure out how to get these schools open safely and sensibly, obviously understanding in the process of protecting the vulnerable. And many school districts now are reopening just that way, safely and sensibly. Second thing I want to say is the risk of infection, COVID in schools, particularly now K through 12, that risk actually, those students don't get the COVID in schools, they get the COVID in their community. So the best thing we can do to help prevent COVID in schools is to control the COVID in the community, which comes back to all of us doing these mitigations. College campuses, very important. First, we have the fastest growing number of cases, if you do age demographics, is that group between 15 and 30. We need to appeal to that group to really listen to that fourth statement that I said, avoid crowds, right? Be smart about crowds, wear your mask, social distance, wash your hands, and be smart about crowds, because a lot of these crowding situations, these parties and these gatherings are really becoming super spreading events. We want to really appeal to individuals that have COVID, obviously, to self-isolate. We do want college campuses to really reflect on their decisions when they do have these outbreaks. We don't believe it's in the interest of our nation to have those students sent home and then reseed all different parts of our nation. We think the students should be able to be isolated on campus. Many campuses have got isolation dorms until there's recovery, and then to try to really stress and enforce the importance of their student body, that this is a chance for them to contribute to America's effort to win the war against COVID by, let's forgo the parties for now. Let's forgo the mass gatherings. Let's all act socially responsible for our fellow schoolmates and for our nation.
I know that one of the things everyone is waiting with bated breath for is a vaccine, and I know that there are antibody treatments in the works in the interim. But with the draft of the National Academies out yesterday on distribution, I'm curious on your thoughts on sort of, first of all, what they've said in terms of the grouping and the priority. Does it align with the strategy that you, or in general, Operation Warp Speed and the task force have looked at?
Well, thank you. This is obviously a work in progress. The National Academies come out with their initial recommendations that really highlighted the four kind of areas that they focus on: the risk of acquiring infection, the risk of morbidity and mortality, the risk of negative impact on societal factors, and of course the risk of transmission of the disease and infection. And so they've proposed a multi-phased approach. It's out now for public comment, and it will go through that process and then come back and they'll issue a final report. That final report will be a component, because ultimately the decision is the decision of the Advisory Committee on Immunization Practices, which is also an independent committee that has credibility in this space for decades, making recommendations on how to use vaccines across the nation. And they will take the National Academy's thoughts under consideration along with their own deliberation, and they'll finally make a recommendation to how they believe is the best way to begin to distribute this virus, this vaccine, in an equitable way to make sure the allocation's equitable across this nation.
Certainly don't want to be spreading the virus there. On the point of the hospital workers, I think there's one thing that I've had a lot of discussions about within the healthcare community, and that is hospitals employ a lot of people. And so when you're talking about, frontline workers receiving and being part of that initial priority, that includes a wide array of people, not just those who are wearing lab coats or white coats and stethoscopes, but those who are maintaining the facilities and work within them. Any thoughts on whether or not those individuals would in fact be included?
Yeah, I think this has to be, again, part of the considerations, but I would echo what you said. When we look at risk to healthcare workers and we broaden that understanding, people that help the health system work, for example, in nursing homes, the risk of infection was not greatest in doctors or nurses or respiratory therapists. It was the greatest in nursing aides, right? So just to echo that in hospitals, that, when we look at the broader issue, it's going to be really an understanding who's at greater risk of infection and how would they benefit that. And again, to try to make those initial allocations in an equitable way that really sets around the priorities. And the major priorities will be obviously risk of infection and risk of bad outcome from infection, and how that gets sorted out in the final recommendations. I have confidence in the Advisory Committee of Immunization Practices. They've already had several meetings. They will be making these decisions based on real data of the vaccines, how they perform, where we know that they're going to be able to be effective and safe. And I suspect it's really going to be those two groups, the individuals greater risk for infection because of their employment, and the individuals at greater risk for bad outcome if they happen to get infected will be the initial groups.
Sure. Looking at all of the changes sort of that the country has gone through, each individual has, personally been affected and changed a lot of their lifestyle. How have you handled, the outbreak, and what changes have you had to make? I know you've also, had to fly to different locations and other things. So what has the experience been for you?
Well, part of it is I'm kind of jealous of my clinical colleagues, because my whole life I'm really a doctor. I practice medicine, and I grew up practicing medicine, taking care of men and women that were trying to confront and live with HIV infection. And I went through some pretty tough times where most of my patients, unfortunately, died in the prime of their lives. So I really miss that practice of medicine. And I really want to applaud the men and women that make the health system work in this nation. It's that same sense of vocational commitment, though, that I want to applaud the teachers now that are stepping up to open up these schools so that the K through 12s can get back to school. So that's first and foremost. I've tried to say one of the focuses of CDC is to make sure that all of the important efforts that we're doing, trying to end the AIDS epidemic by 2030, combat, teenage nicotine addiction, going after drug use disorder to make progress, confronting maternal mortality. I've told the team we can't let those public health objective goals go on the sidelines here, that we have to keep those moving forward right now to make, progress. So 700 women die in this country a year just giving birth to a baby. We have to really continue those efforts and make sure that we don't have that. So, I continue to be optimistic that we're going to come out of this stronger, with a stronger public health system in this nation. Clearly, that's one of the areas that I think people opened their eyes to, that we have underinvested in public health in this nation for far too long, for probably over 50 years. And it's time to make that investment in data modernization, laboratory resilience, public health workforce, in our global health security footprint around the world, so that we're well prepared to confront the pandemics like this. Right now, I will say we're preparing earnestly for what I anticipate will be reality, is that there'll be one or more vaccines available for us in November, December, and we have to figure out how to make sure they're distributed in a fair and equitable way across the country. I will say the first couple years at CDC, it was the time of my life. I love science, I love data, I love service. I'm surrounded by over 20,000 men and women that are trying to use their skills to improve the human condition day after day, and I saw progress. I will say the last 9 months, I'm in the middle of war, because this is a real battle. This is one of the most critical, complicated public health crises that this nation has faced in over a century, and to extend it the world. And to sort of be in the middle of that, it's a big effort. I mean, it's an honor, but I sure liked the first 2 years a lot more, because I was seeing meaningful progress in making meaningful improvements in a variety of areas, all the way from one end, from drug use disorder, all the way to another area, that ending the AIDS epidemic, fighting an Ebola outbreak. I'm on my third Ebola outbreak now in the Congo since I've been CDC director, taking on the increase in nicotine use among high school and middle school and elementary school thing, and trying to reverse that, going after maternal mortality, trying to make meaningful programs to confront health disparity. I mean, every day was kind of fun, because I was trying to divide my energy and encouraging different really talented people to accelerate their efforts to improve the human condition. In the last 8 months, it's been very focused on helping this nation confront the war that we're fighting against this pandemic. And I'll close.
It's been really a significant change for you, I'm sure, just in daily operations.
Big change.
And there's been a lot of political sort of back and forth as well. I'm curious about the World Health Organization and other bodies globally. Has the political tension affected your ability to work with colleagues overseas?
No, it hasn't myself. I think in general, people see CDC for what it is. It really is the premier public health agency in the world. And we're really focused on that, is how to use data and science to improve the human condition, stay focused on that lane. I do have to, try to encourage my colleagues, because they're really outstanding men and women that work at CDC, not to get distracted by the critics. Sometimes I wish the critics would understand that they do have the potential to suck energy out of people that are trying to do the right thing for the right reasons. So the criticism is not always benign. It can actually change the enthusiasm, the earnest. And so I think the hardest thing and the most important thing that I do as a director now is remind the men and women how important they are, how valuable they are, how their work is valued, and how they have to stay focused on, if we'll say, focused on the goal line, and not get by some article in the newspaper or some criticism on one of the news shows. That, this is an agency that's not used to having negative criticism. So, but I will say that We've worked, earnestly. When I got the first models back in late February, early March, it was a very difficult time for me because those models by very smart people in my agency told me that they anticipated 1 million to 2.4 million people would die of COVID before October 2020. That was catastrophic if you start to think about that. I think we all committed to do all we can to try to save human life. It's always hard to prove what didn't happen, but I do believe that the efforts that have been made over the last 8-9 months have had an enormous impact on saving human life in this nation.
Certainly hope that we can continue that trend going forward. Dr. Robert Redfield, Director of the CDC, thank you so much for your time today.
Thank you very much. It was a pleasure to be with you.
Joining me now is the Surgeon General of the United States, Dr. Jerome Adams. Thank you so much for joining me today, Dr. Adams. Great to speak with you.
Really glad to be here with you.
I know that it's a tough time out there with so much going on with the mask debate, especially as we're seeing so many cases rise across the U.S. and continuing to do so. Could you tell us about what the logic is and what the thinking is at the federal level about not requiring a mask mandate?
Well, I appreciate you asking that because there is so much focus on whether or not we should force people to do something. And I think not enough focus on the need to educate people about why they should do it. Strictly from a public health, motivational, and behavior change perspective, it's important to know that we don't have much luck when it comes to trying to force people to do something if we don't couple that with the why. We know that if you force people to do it, they'll do it when you're watching. But then when you aren't watching, they'll stop doing it. We also know that shame doesn't work, and that's true for opioids. That's true for STDs. That's true for HIV testing. What I'm focused on as Surgeon General is helping people understand a couple of things. Number one, COVID-19 has really humbled us in terms of its asymptomatic spread. Really quickly, what that means is that previous diseases like COVID-19, other coronaviruses, really weren't spread by people who didn't have symptoms. You knew if you were sick, and if you were sick, then you were one of those people who was more likely to spread the disease. But up to 50% in many cases of people who are spreading COVID are spreading it before they have symptoms and without ever even knowing they have it. And that's why our recommendations change to tell people to wear masks or face coverings. The other important thing I want people to know is that masks actually don't inhibit your freedom. They don't inhibit your choice. They enable freedom and enable more choices, because we know that if we can get 90% of people to wear face coverings and get people to practice at least 6 feet of social distancing from their neighbors and practice good hand hygiene, that we can reopen and that we can stay open and we can get back to schools, to worship, to college football in the fall, and to the other things that people want to do. You'll have more choices if you wear a face covering.
There has been some debate and comparisons about, seatbelt enforcement and other things like that. Would you say that those are fair comparisons, and that even if at the state level there should be some level of enforcement?
Well, I'm not opposed to mandates at the state and the local level. We actually support local control and state control. Here's the concern when you talk about enforcement from a federal level, and this is a very practical concern. This isn't subjective. If the difference between a mandate and a guideline is enforcement. And from a federal perspective, we can send in federal troops, and we see that's not working very well in places like Oregon right now, and that there are also concerns about enforcement when you look at what's happened in the African American community and people being killed for very minor offenses. And we also could take away federal funding, which I think is a very tough thing to put on the table at a time when we're fighting a global pandemic. And then there's civil penalties. Again, all of these things work best and become less necessary if implemented at the local level and coupled with education. And so, again, not against a mandate, but really against doing things without making sure people understand why they're doing them, and working with the local communities to make sure everyone understands that we all benefit when people wear face coverings.
Dr. Adams, one of the things that you're really focused on is diversity, and especially looking at how the virus has been disproportionately impacting certain communities. What has been done whether at your office level or generally with the coronavirus task force with addressing these? Because we've been hearing about them, but there hasn't really been any action.
Well, we should be shocked by the statistics. Native American, Alaska Native, and Blacks, 5 times the rate of hospitalizations. Hispanics, 4 times the rate of hospitalizations. And we know that a disproportionate number of the 140,000 people who've died of COVID-19 in this country have been people of color. That should shock us, but it shouldn't surprise us. And what I mean there is we've known for over a century that people of color are disproportionately impacted by an array of diseases, from cancer to heart disease to diabetes and to substance use disorder. And really what COVID-19 has done is shown us those health disparities that have existed in communities of color for all of my life and have impacted me and my own family personally. So you ask what the task force is doing. We're trying to, number one, improve data collection. And the CDC now collects data according to race and ethnicity. That wasn't happening before and still isn't happening with a number of other diseases because it involves a level of coordination that goes beyond the federal government. Again, it may start at the local coroner. It may start at the local hospital where a person is admitted and you need a busy nurse to write something by hand and to fax it in. We're looking at improving those processes to make it easier for people to do the right things. We're doing more research. The National Institute on Minority Health, which is a part of NIH, is doing research regarding how we can make testing more available in communities and making sure we've got urgent research done to ensure the remedies that are available, like remdesivir, like steroids, like convalescent plasma, work as well and are equally available. And we're also working, and this is critically important for your viewers to understand, we're working with communities to make sure they are participating in vaccine trials because we want everyone to understand that vaccines are safe and effective, and we want people to feel confident that they're safe and effective in all communities so that we don't actually worsen disparities with a vaccine, which could happen if the people who are least affected get the vaccine and the people who are most affected from COVID-19 won't get the vaccine or aren't equally helped by it. That's just a small sample.
How do you ensure that, though, when it comes to the clinical trials and making sure, obviously the distribution you can sort of look at, but when it comes to clinical trials, is there any sort of mandate for diversity?
Well, there are guidelines that we have within HHS to really help people understand within the agency that we need to go above and beyond to recruit people into trials. But at the end of the day, you can't compel someone to participate in a clinical trial. We can only be aware of it and have outreach, and that's what we're doing from the HHS point of view. Just today, we released new guidelines from the Office of Civil Rights, helping make sure there was no discrimination, not only within government, but within healthcare facilities according to race and ethnicity. And so these are things that we're doing to try to make sure people understand we recognize the severity and the impact of health disparities, and we're putting meaningful action into place to decrease those disparities. One more real concrete example that I think is important for COVID: we have over 2,000 community-based testing sites, and 70% of the community-based testing sites that are federally supported are with a high social vulnerability index, meaning largely communities of color and places that have risk factors like poverty in those communities. And so we really are trying to direct the resources to the people who are most impacted. There is meaningful change going on, and more funding going to HRSA and to Medicaid, again, which also serve people of color. It is not to say mission accomplished. We are nowhere near where I would like to be as a public health advocate and as a Black man and a Black doctor, but we certainly have moved very quickly on some issues that I've been advocating for my entire public health career.
I know that you're at the top level and seeing all of this change, but I think generally we're still looking at what seems like a repetition of what happened back in March when it comes to a shortage of testing availability, long turnaround times, shortage of reagents and other supplies, as well as protective gear. So while you are seeing this, I don't know that at the general public level, we're actually hearing that. So can you tell us about how that's going to be resolved?
Well, thank you for that. And I think it's important to acknowledge the urgency of now. Over 60,000 cases per day. We do not want this. This is not a good thing. And it's why, again, we're focusing on that prevention message. But it's important for people to understand we are in a very different place than what we were in February and in March in a couple of ways. PPE, personal protective equipment, has increased by over 300%. You are no longer hearing about healthcare workers dressing up in trash bags and having to make do with substandard equipment. It's not that we're where we need to be, but we are in a better place. Remdesivir, steroids, convalescent plasma means that the mortality rate is much lower than what it was back then, that people are getting out of the hospital sooner because of advancements in technology that have occurred. We are, in fact, doing a better job of protecting the vulnerable. The average age of diagnosis has dropped by a decade and a half. We know originally this hit nursing homes and the elderly particularly hard. So we are in a very different place. That's not to say we should pat ourselves on the back, but it is to say people should understand you have a much better chance of surviving if you get COVID-19 right now, and that you have a much lower rate of spread among healthcare workers and other individuals on the front lines, and that we need to continue to do our part to support that effort by wearing a face covering, by washing our hands, by maintaining 6 feet of social distance, and by avoiding large gatherings whenever we can.
Really quickly, an update on the task force. A lot of stuff obviously going on behind the scenes, as has been the case, but for the general public to understand, what is the latest in developments? And can you explain a little bit about what attention has been placed on testing, as well as why data was moved from the CDC initially?
Well, the task force is a group of individuals from across government. We have the cabinet secretaries. We have an array of different physicians, myself, Admiral Giroir, Dr. Redfield, Dr. Hahn, Dr. Fauci, Dr. Birx, and we all come together and quite honestly, we hash it out. We put the tough issues on the table, and while we don't always agree, we know we've got the advice of the best people in the country on these issues, really helping us develop policy for what is a novel disease. Again, it's important for folks to remember this disease is still in its infancy. It's barely over 6 months that we even knew that it existed. And when you look at therapeutics, when you look at the change in our stockpile, when you look at an array of factors, we've come a long way in a short amount of time, and we have to continue to keep our foot on the gas because still far too many people are getting affected, far too many people are dying from this disease. You ask what the task force is focused on now. We're focused on communities that are hardest hit. So we know that this disease isn't out of control everywhere. Actually, in most of the country, the disease is under control. There are hot spots. Arizona, for instance, is level or falling if you take out Maricopa County. It's why we sent a CDC team to Maricopa County. I will be going to Miami, Florida. That's another hot spot later this week to make sure everyone on the ground there understands what federal resources are available. We're focused on making sure we're putting out the fires where they exist. And also, again, helping people understand the best tools that we have are really in the hands of the public. It's why I have out my hashtag COVID Stops With Me campaign, urging the public to do their part, because we want to be there to help protect people. We want to be there if people get diagnosed to make sure they get tested, to make sure they get treated. But I don't want you to get tested. I don't want you to have to get COVID in the first place. And you asked about testing, so I'll quickly touch on that. Important for people to know that about 25% of the testing in the country is point of care. That means you're getting your results back in under an hour. Another quarter of testing is done in hospitals, which means you're getting your report back in just a few hours. So only about 50% of testing is done in large commercial labs, and we follow those numbers every single day. And the turnaround time is about 3 to 4 days, which in my opinion needs to be improved. The quicker we get that information back, the quicker we can tell someone whether they should isolate or not, and then to do contact tracing. But the fact is, the stories that you're hearing about 2-week turnaround times, I don't deny that that's happening in some places, but the data just doesn't bear out that is what's going on across the board. We're doing over 800,000 tests per day when you look at the numbers for last week. We have improved. We've just got to do a better job of making sure we don't have so many people who need testing and who are getting diagnosed in the first place, because at some point the demand will always outstrip the supply if you have increasing case numbers. We need to drive those case numbers down, and while we're also increasing testing and getting it to the people who need it the most.
Certainly. I'm going to pivot to your health and economic prosperity report in just a second. But before that, I just wanted to get an update on the conversations with the president. Have you had them, and what are they like right now?
So again, the task force meets multiple times a week as the larger task force, and subgroups meet throughout the week. So every single day, people on the task force are working to make sure we're improving guidelines, that we're tracking data, that we're doing outreach to communities. As a matter of fact, before speaking with you, I was just on a call with a large number of community stakeholders from across the nation talking about ways we could address disparities in COVID-19 outcomes. That information from the task force goes directly to the vice president. He's at every single task force meeting, and then the president is briefed by the vice president every single day. And the president occasionally comes down. He's a busy man. He's working on a number of different things. Comes down and participates in the task force directly. So the bottom line is the president is getting information from the task force every single day. And it's a process that we're constantly trying to improve. But I've got to tell you, when I sit at the task force meetings, I'm surrounded by the best scientists in the entire nation. Dr. Francis Collins, Dr. Deb Birx, Dr. Tony Fauci. And again, that input is being given to the President of the United States, and that's all that I can ask for. And I want the American people to know that I and the other physicians are doing everything we can to make sure we're providing good and sound advice.
And this report that you've made as such a priority, I know that generally speaking, there's been sort of this patchwork approach and sort of independent organizations or independent communities really taking it on themselves to address these health disparities. What is it you're looking for? I know that there's already been HHS support for that Morehouse School of Medicine project, but where else do we go from here, and what are you looking to achieve?
Well, we know that the U.S. spends more money on healthcare than any other developed nation, westernized country, and gets actually some pretty poor results for their investments. This is what we call the U.S. health disadvantage. We know that this U.S. health disadvantage is actually hurting not just our own health, it's hurting our economic competitiveness. The number 2 cost for most Fortune 500 companies behind salary is healthcare. We know that poor health also impacts whether or not people show up to work and how productive they are while they're at work. It impacts workplace accidents. It impacts the ability to recruit a healthy workforce. We know that in many places that were hard hit by the opioid epidemic, they can't staff factories because they can't find enough people who can pass a drug test. This is the U.S. health disadvantage. And what really concerns me, and this report started well before COVID-19, but COVID-19 has shown a magnifying glass on the problems that exist here, that in many cases, health is pitted against economics. And we've seen this happen with COVID. If people want to say you either are for reopening or you're for keeping people healthy, I want folks to understand that these two can't be de-linked from one another. And what we're doing is really working with the Chamber of Commerce, the Business Roundtable, working with UVA's Darden School of Business, working with business leaders to help them understand that when businesses invest in the health of their communities, they see not just health metrics improve, but they see business metrics improve. Again, people are more likely to be at work. They're more likely to be productive. These businesses become employers of destination for younger folks who are looking for places to move their family to. And if we can do that, then we can actually get more people on board with creating the environment that allows everyone to make healthy choices and puts everyone in the best possible position to live a long and healthy life. And we will lessen disparities because personal responsibility is critical, but the choices people make are 100% dependent on the choices they have around them. And far too many people, especially people of color, don't have the opportunities, the choices in front of them to be able to make an appropriately healthy choice for them and their families.
Thank you, Dr. Adams. And one final quick round question for you. There's been a lot of discussion on between medical experts about there being a lack of a federal response. Are you under the impression that there's a lack of a unified federal response to the outbreak?
Honestly, nothing could be further than the truth. I'm working 24/7 and all the other doctors are working 24/7 to coordinate a federal response. I used to run a state Department of Health for 3 years. It's important for people to understand that you can't do everything from Washington, D.C. that the majority of the work and the majority of the authority is at the state and local level within the public health systems. And so what we're doing is working closely with state and local health departments. Again, I'll be going down to Miami, Florida soon after this to meet with the Surgeon General of Florida and to meet with the governor. I was in Georgia a few weeks ago meeting with their health commissioner and with their governor. We have weekly calls with the governors. We are really trying to have a federally supported, state-led, and locally executed response. And that's the way public health works in this country. And that can be frustrating for some people, but it's also where we get a lot of great innovation from, because we know what works in Billings, Montana isn't what's going to work in downtown New York City. We really need to give the flexibility for local response, but we need to make sure there's federal guidelines, which we offer, and federal support, which comes from Congress, to make sure those state-led and locally executed responses are a success. And that's what we're trying to figure out and push with the task force. And again, while I would by no means say mission accomplished or say that this has been a success, I would say that I'm proud of the work that the CDC has done, that the members of the task force have done, that NIH has done, that the federal government is doing to put us in a position to be able to defeat this disease. And I think that we can defeat this disease if we can get the public to do their part, and we can get state governments and local governments and the federal government to all work together. And I'm seeing more and more of that.
Dr. Jerome Adams, U.S. Surgeon General, thank you so much for your time.
Thank you. COVID stops with us, and we can do this. I am 100% confident we can defeat this disease. We know that in just the course of a couple of weeks to months, Italy went from being one of the hardest hit in the world to actually now being open for tourism and having schools open again. We can be there too if we just all do our part, put the politics aside, and actually do what it takes to overcome this pandemic.